See, earlier we used to be using them, but then we had this fear of, neuromuscular blocker related polyneuropathy and therefore delayed recovery, all those things. But then now it is pretty clear that that initial part of ventilating somebody with a moderate to severe, that really, really bad lung, that really bad, the stiff lung, is very tricky, and we are doing all these things. Positive pressure ventilation itself is aphysiologic because our spontaneous breathing is negative pressure breathing. First of all, you institute positive pressure breathing. On that, you're going to tell the patient to breathe like how you want to. You're going to vary, you are going to play around with tidal volume, you're going to play around with the pressures, you're going to play around with the IE ratio. So definitely you cannot allow the patient to also be breathing by himself. So there gives a whole lot of mismatch, producing what is known as SILI, S-I-L-I, self-inflicted lung injury. Now, this is something that we have started identifying more often, and this becomes a self-perpetuating process. Okay, you're trying to do something on one end, and something bad is actually happening on the other end. So it is clear that in the first 48 hours at least, maybe more, okay, if the lung continues to be bad, you cannot stop short at 48 hours. At least for the initial 48 hours, when you are ventilating somebody with very, very bad lungs, you have to use neuromuscular blocker, preferably as an infusion, and ideally with the train of 4 monitoring. But let me again get back to resource limiting. So a suitable infusion volume you need to identify. Of course, the original trial studied cisatracurium, but whichever is applicable to your setting, even if it is a vecuronium or a pancuronium, it is still okay. I don't think this is a time point where I will be worried about critical illness, polyneuropathy and myopathy. We can always get our patient out. Of course, yes, that's going to keep the patient for longer time on ventilation, but that's okay. Right now we are talking about life and death. Okay, so this is another paper, not the best quality paper, which raises the concept that you will not stop paralysis just because it is 48 hours over. Okay, you go by the physiology, you go by the improvement in compliance. If the lung is not yet improved, then just because it's 48 hours over, you cannot stop. But I'm quoting this paper. It's not a good quality paper, but the concept is something that you need to think about. And of course, this is a good quality paper, but this raises a concern that even if you use neuromuscular blockers, the survival is the same whether you've used or not. But see, this is again not a time where we are talking about mortality as the end point. Initially I want the lung to get its rest, its due rest. I want to meet with physiological goals. I want to meet with oxygenation targets, and then we can always take care of the remaining. And again, mortality is not just because of the lung or because of the way I ventilate, it's because of so many other confounding factors. Okay.